Good afternoon, everyone. I welcome you all to ET Health World webinar. To present this webinar, I welcome Dr. V. Mohan, Chairman, Diabetes Specialty Center, Gopalpuram, Chennai, and share valuable insights on the topic Preventing Clinical Inertia in Diabetes. There will be a presentation on the topic followed by a Q&A session wherein you may submit your text questions to today's presenter by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect those and address them during the question and answer session at the end of the presentation. Now I request Dr. V. Mohan to start the presentation. Over to you, sir.
Thank you so much, and I'd like to thank ET Health for arranging this webinar. It's a great pleasure to interact with a wide audience from all over the country and probably abroad on this topic. When I was asked to talk, I thought I would choose a topic which is of great topical interest and something which is not discussed very often in the literature or in the scientific conferences, but which to me appears to be the most important thing in diabetes, and that is prevention of complications. If you think about diabetes, it is increasing in epidemic proportions, and I'll show you in the next slide what happens. But the most important thing about diabetes is not that more and more people are getting diabetes, but that nobody should develop the complication. People should be able to live 50, 60, 80, 90 years with diabetes without any complication. Just a minute ago, I was downstairs and a young boy with type 1 diabetes has come from Calcutta. He is about 16 years old. And I was telling him, now you plan for your to live up to 100, and how are you going to achieve that? That's the main thing, without having any complications of diabetes. Now, what prevents this, in my humble opinion, is what is called as clinical inertia. There is a lot of inertia. People hesitate to do things which they should be doing, and that's what actually leads to the complication. And today's whole topic is how to prevent that inertia and thereby prevent the complications of diabetes. I'm going to start at the very beginning, and this is from the International Diabetes Federation, the IDF Atlas, 8th Atlas, which was released last year in November, which shows you the number of people with diabetes in the world in different countries, the top 10 countries. On my left-hand side, 2017 is shown, and then on the right-hand side, 2045 is shown. And if you look at the 2017 figures, China is actually in the first place, the leading country in the world with the number of people with diabetes, currently about 114 million. And India is in second place with about 73 million people. But according to the IDF, in the next few years, all that will change. And India will then ascend to the first position. And the numbers quoted here are 134 million, which is almost double of what we have now. China, interestingly enough, from 114 will remain around 119. Now, why is that so? We won't go much into this, but it has something to do with today's talk, and therefore I'll just mention it. India, by that time, would have overtaken China with the number of people that we have. China's population is already steadied out. It's not increasing anymore, whereas India's is still marching ahead, in fact, galloping ahead. So next 5 to 6 years, our population will overtake China. Now, the second thing about China is that it has a very large old people, large number of old people, elderly people. So those who have to get diabetes have already got it. Many of them are about 60, 70. Their mean lifespan today is 85 years. In India, it's 69, 70. In another 10, 15 years, Indians are also beginning to live much longer. So those who now go on to 60, 70, 80, they'll all get, many of them will get diabetes. That's the second thing. Third thing is China has much more obesity than India, but India is fast catching up. Our obesity rates are going up very rapidly. Because of these three factors, mostly because India's population itself is going to beat China, there is no doubt that India will have the largest number. Whether it's going to be 2045 or 2025 is debatable. I think it's more like 2025, 2030 when India will reach these numbers. Very conservative figures are always given by world bodies. They don't want to frighten people. Okay, so the point is we have a lot of people with diabetes. And assuming that even a fraction of them develop complications, we're going to have a huge load of complications in this country. Now, one of the drivers of these complications is poor diabetes control. Many of you will know that HbA1c is a test which tells us about 3 months control of diabetes, and the normal value should be 7% or below. Study after study has shown that if you maintain the A1C level less than 7%, you virtually don't develop eye, kidney, or nerve complications. You may still get heart or heart complications, heart attacks or strokes, but that has to be prevented by checking blood pressure and controlling lipids, stopping smoking, doing pranayama, yoga. There are many other things you have to do to prevent heart attack. But the three main complications, eye, kidney, and feet, nerves, can be completely prevented by just this one test, A1C being less than 7%. And yet, this is a study we published some years ago on behalf of the Diabcare India studies, an all India study, where we looked at what is the A1C in diabetic clinic populations. This is not in the population. This is in diabetic clinics where endocrinologists and diabetologists are treating. The mean A1C is 8.9, almost 9, plus minus 2. That means it's going up to 11 in many cases, where it should be 7. So it's not at all surprising that people are getting these complications. More recently, we have the ICMR India diabetes study, or the ICMR InDiab study, and these are the results of the first 4 states of India, where north, south, east, west, we picked one state each. Now the whole study almost in all the 31 states is being completed, but in 2014 we published the first 4 states. And so the other one, what I showed you, Diabcare, is from diabetic clinics or endocrine clinics, and one might argue that the worst cases come there. So this may not be representative of the population, and so that 8.9 may be a false figure because you're seeing the worst cases. Now this is actually going to people's homes in urban and in rural. So this is the actual statistics in India in these 4 states. And believe me, we have now finished 24, 25 states. The results are almost same all over India. What did we find? If you take an urban is shown in green and in orange is the rural population of these 4 states. If you look at those who have good diabetic control, defined as A1C less than 7, only 30% of people in India have an A1C less than 7%. Now, these are not the worst cases. These are all the cases which are there in that state. And only 1/3 are under control. Another 1/3 have A1C up to 9%, which is actually bad. Above 9 is terrible control. Another 1/3 are like that. In rural areas, it's almost 40% having such poor control. So if you take the whole of India, the diabetic control is not satisfactory. That's the message is coming out from this. This itself is a sign of clinical inertia. Something is going wrong somewhere. People are not doing what they should be doing. Either the patients are not doing, or the doctors are not doing, or both are not doing. Somewhere some inertia is coming. I would have liked everyone to be below 7%. Once you're detected to be diabetic, everyone should be below 7%. Then you won't have complications of diabetes at all. Now, what is the evidence for this? Here is evidence from this. This is a paper published in the BMJ. What is the incidence of complications, new onset complications, based on the A1C levels? And you can see that if it is 5 or 6%, the complication rate is very, very low. We may say, why should you have complications at all there? Because they may not have had 5 or 6 earlier. Now they might have come to 5 or 6 after controlling. After they develop complication, they might have got frightened and they would have brought the A1Cs down. If you really maintained it at 5.6, nobody will have complications. Virtually 0 it is. But look at those who have 8, 9, 8.5, 9.5, 10.5. Your prevalence of complications is doubling, tripling, okay, with the A1C. So one of the targets that every diabetic clinic, every physician, and every patient should aim for is to keep those A1Cs below 7%. That's the first and the most important message I want to give you through this webinar. Everyone's A1C should be below 7%. Then you will not develop the small vessel disease due to diabetes. Those are the specific ones. Heart attack can get even without diabetes. But the nerve, the eye, and the kidney are only due to diabetes. No other disease produces that. And those 3 complications can be wiped out if your A1C is below 7%. Now, this is the actual burden. I showed you the burden due to diabetes. I said 73 million and so on, the idea of statistics. Now, these are our own population-based data on all the complications of diabetes: heart disease, peripheral vascular disease affecting the feet, gangrene, eye, retinopathy, kidney, nephropathy, and nerves, neuropathy. U is urban, the urban prevalence, population-based. Again, this is not from the clinics. It's when you went home to home, and check people in urban areas, in Chennai specifically. R is rural. This is rural Tamil Nadu, about 100, 200 kilometers from here, from Chennai. We went to people's homes in villages using a mobile van and then checked their status. And what we find is that about 20-25% of patients have one or more of these complications. And if you take kidney disease, nephropathy, for example, the fourth one, nephropathy, again 24-25% having kidney disease. We know that kidney disease, diabetic kidney disease, is the deadliest because it's a cause of a disease which will continuously go down and down and down till it takes you into renal failure. And once it is fairly advanced, it's very difficult to treat it or control it. In the early stages, you can prevent it. In the early stages, you can reverse it. But if you miss the bus at that stage, then it's going to go on and on until it takes you into kidney failure. And 1/4 of people having it, 25% is 1 in 4 people having it, means that if you're talking about 75 million people having diabetes, 1 in 4 of that, some 16 million, 17 million people, as shown the number at the bottom showing millions, is in 2011, we estimated that 17 million people had diabetic kidney disease in India. Now it will be much more. It's probably 20-25 million. That's more than Australia. It's more than Australia's population. Just not people with diabetes, diabetes with kidney disease in India being so very high. Okay, so these are very frightening. And if you look at the costs of the kidney, either to do a transplant or to do dialysis, there is nothing there's nobody will be able to afford it. No NGO, no government will be able to treat everybody. These millions and millions, 25 million people with kidney disease, if you see, it's just not possible. There are not enough doctors, there are not enough technicians to do that. And that's why clinical inertia must be prevented to prevent the complications of diabetes. Now I'm going to show you this figure. It's a cartoon. It's a slightly made up cartoon, but it drives home the point. It's actually from another Dr. Brownlee who first published this. Then I modified it in a cartoon form to drive home the point. It's a very powerful slide. Now, what is shown here, if you look at the left-hand side, HbA1c of 7% is shown. Okay, and that's where it should be. So I'm just assuming a patient came to me today and the HbA1c is 7%. So it's very good. We have achieved what we wanted. But what people forget is that it's not going to remain at 7% all the time. Diabetes is always trying to increase in somebody's body. Why? Because the beta cell function, the amount of insulin that we have as we measure through C-peptide, is constantly going down. So once it is going down, the A1C will keep increasing. So just because it is 7 today, it doesn't mean for the next 5 years it's going to be 7. Next 3 months it may go to 7.5 and 8. Today sitting in the OP, many people who had good control, they have come back after 6 months, 1 year, the control is gone, completely gone. And if they had not come, it would have gone higher and higher and higher. That's what this graph is telling you. At the bottom, those lines that you see is a hypothetical one to show you number of months. So if you delay for say 3 months, then little bit it would have gone. If you delay for 6 months, much more it would have gone. If you delay for 1 year, it's going to go much more. And you delay for 2 years or 3 years, it's going to go still higher. Okay, so what happens is, if you draw that line at 7%, anything above that 7% is what we call as a glycemic burden. Suppose 8, 9, 10, whatever, from that 7 onwards up to whatever the value that you have, 8 or 9 or 10, there is a burden that the patient is carrying with him or her. How do we reduce this burden? One way is to get the patient back earlier. So this is, I'm assuming, say for 2-3 years they didn't come. See where they have gone and how much glycemic burden they are accumulating. On the other hand, if the patient came back there, okay, so what would have happened? Because the patient came, the A1C would have been somewhere there, and we would have immediately taken steps to bring down the sugar level. We would have adjusted the medicine, adjusted his diet or exercise or insulin or tablets, motivated the patient a little bit more, frightened the patient a little bit more because they won't listen, and then the patient will immediately take steps and bring it down. So what happens? The red one is avoidable. Because the patient came now, From then on, we have avoided all that. But the green one which is there is unavoidable because he came only then. Only after he comes, we can bring down. So that is unavoidable. This is avoidable. Now see what happens. Suppose a patient had come earlier, then the avoidable is increasing. The unavoidable is decreasing. Suppose they came earlier, then only that much time the sugar would have been high. The burden would have been there only then. The rest of it we would avoid it. And still earlier. That is why we say every diabetic patient must be seen every 2 to 3 months. Okay, when we say every patient, whether you're well, whether your A1C is okay, not okay, every 2-3 months if you come, then we will immediately correct it, take the corrective measures immediately, and thereby the entire glycemic burden is avoidable. And you have only a very small unavoidable burden which will not affect you. Because in 2-3 months, again you're going to bring it back, again you're going to bring it back, again you bring it back. This way you can do it. Now, if you don't do it, it is a classic example of clinical inertia. Somebody has failed. Either the patient has failed, or we have failed, or both have failed. We have failed to prevent that glycemic burden from coming down. Okay. So we addressed this a few years ago in a paper that I wrote with a group from abroad, where we said time to do more. You have to address clinical inertia in the management of type 2 diabetes. And we made a strong plea in this, saying that we wrote this in 2014 actually. So we said we defined clinical inertia and we said this is what we should do. You should bring down the burden. So let's look at how to define clinical inertia. Clinical inertia is defined as the lack of treatment intensification in a patient not at evidence-based goals for care. The evidence-based goal for care for sugar and A1C is 7%. If you are not at 7%, you're at 8%, and you didn't do anything to bring it down, you have created clinical inertia. There's another definition for it: failure of the healthcare providers to initiate or intensify therapy when it's indicated. I'll modify the definition a little bit after a few slides. You also have to de-intensify sometimes, okay? But I'm talking about intensifying the treatment in somebody in whom you can intensify. And that's defined as clinical inertia. Now, in a paper which is just going to get printed, you can see the date of this, January to April 2019. It's not yet come. Okay, but I'm showing you a preview of this, like you see a cinema preview. I'm giving you a preview into this paper which I wrote, because I think it's the first paper in the world to actually write on the expanding concept of clinical inertia. I've actually expanded the concept and said it's not so simple. It's not that A1C alone 7%, that's too simplistic. Of course it's important, but it's too simplistic. So I'm expanding the whole concept and saying clinical inertia is much more than that. So what does it mean? Let's look at this. This is the natural history of type 2 diabetes or even type 1 diabetes. Okay, you see the green, that is called normal glucose tolerance. They don't have diabetes at all. They've done GTT, they've done everything, all normal, HbA1c, everything is normal. Then comes a stage of pre-diabetes, where the sugars begin to go up, but they have not reached the cut points for diabetes. So we call it between normal and diabetes, it's called pre-diabetes. Then comes a stage where you have diabetes. By any criteria, fasting, 2 hour, random, urine sugar, whatever symptoms, everything will be there. That is clinical diabetes. And the last stage, which nobody should go into, and that's what this whole talk is about, is the complications of diabetes. Okay. Now, if you see at the bottom, I have written what all prevention you can do. Okay. Let's start from the last. Suppose they've already developed some complication. One eye is affected. Now they have come to us. We can try to save the other eye. We can try to save the kidney. We can try to save the feet. Okay, we can try to reverse those eye complications if possible. That is called tertiary prevention. It's a very late stage of prevention, but we can't give up on patients who come at that stage. So even there, we try to do something to help the patient, but it's a bit late in the day. Let's move to second one. They've come to us now. They have diabetes, but they have no complications. Now we have a golden opportunity to prevent the complications. That's why I said HbA1c less than 7, all those things. That is secondary prevention. If you take your treatment properly, you need not get complications in your lifetime. That is secondary prevention. But we expand that, and now you go to pre-diabetic stage, which occurs a few years earlier before that person got diabetes. You have now seen a person who's in the pre-diabetic stage. Who comes to you with pre-diabetes? Family members will bring. They'll say, doctor, I got diabetes. My son is a little obese. He's 20 years old. Why don't you see him and see what he has? When you check up, he'll be in pre-diabetic stage. They'll say, good that you brought him. Now we can try to prevent diabetes itself. That is called primary prevention of diabetes. But before that itself, even before pre-diabetic stage, in the normal glucose tolerance stage, when you have risk factors for diabetes, you're already obese. Your GDT is normal. You don't have diabetes. HbA1c is normal. But you're already obese. You're eating the wrong food. Okay? You're having too much of stress. You're not doing physical activity. At that stage, if you introduce lifestyle changes, lifestyle modification, healthy diet, exercise, reduce stress, reduce weight, that is called primordial prevention. Even before primary prevention, you have primordial prevention. So the concept I'm writing in that article, the new article, is clinical inertia can be there at every stage. If you are in the primordial prevention stage and you're not addressing that in the community, you're not asking people to be healthy, to reduce weight, there's clinical inertia there itself. Then you got pre-diabetic people. You didn't tell them about pre-diabetes, you didn't tell them to prevent diabetes. There is clinical inertia there also. Then they get diabetes. You're not told them about preventing complication. You're not taken enough steps to keep their HbA1c down. Clinical inertia there also. That is the classical clinical we're talking about. And lastly, after getting the complication, you're not trying hard enough to give him or her a normal life despite those complications. There's clinical inertia there also. So that's the concept I'm saying, that at every stage clinical inertia is there. Nobody in the world has talked about this till now. I feel this is a very important concept. Okay. Now, I've also put down in that paper what happens. At the population level, if you don't take enough steps, you will increase type 2 diabetes. In pre-diabetic stage, if you don't do anything, you're losing an opportunity to prevent diabetes. In those with new onset diabetes, if you don't screen, people who have diabetes will have diabetes, but you won't know unless you do screening. If you don't do that, you're going to delay the diagnosis. Okay. Those who have established diabetes, if you don't control the diabetes well, they will develop complications. And finally, those who have complications, if you don't act then, you lead to renal failure, heart attacks, amputation, stroke. So see how much of window of opportunity God has given us to apply. And if we just all work on this together, we can reduce that burden of diabetes. Here is the idea of telling us that your number is going to go from 72 million to 134 million. It's not happened yet, no? They only told us it's going to happen. Why should you wait until it's at 134 million? Can we prevent in that extra? Okay, these 72 million have already got it. Can we prevent the other 60 million or 70 million from coming? If we all work together as a society, if we all work together, we can prove them wrong. We'll say, no, in 2045, we'll have only 80 million, not 130 million. Imagine 50 million people in India are protected from getting diabetes, saved from getting diabetes. Imagine they'll never go blind, they'll never have kidney problem, they'll never have heart attack, that's a huge victory as far as India is concerned, and for any country is concerned. Okay. Now, around this time, my good friend Kamlesh Kunti from Leicester, University of Leicester in England, he brought in a slightly different concept of clinical inertia. I mentioned intensifying the therapy in those who need to be intensified. A1C is 8, 9, you have not brought it down to 7, that is clinical inertia. He says there's another type of clinical inertia where you're over treating. Somebody who should not be at 7 and 6, you're over treating. So he says there are two things. One is clinical inertia. Yes, we understand all that. But the therapeutic inertia, there's something called therapeutic inertia. If you don't de-intensify the treatment, even today we had a patient who was almost 80 years old. Just now before I came, I told him you're taking too much insulin. Reduce it. Reduce your dose. Allow your A1C to go a little higher. That is safer for you. Because in old people, there is a risk of over-treating. To over-treat also, it is very bad. Okay? So therapeutic inertia deals with both intensification of treatment and de-intensification of treatment. So whom do you de-intensify? In those who are elderly and who have what is called as the frail diabetic phenotype. If you have a frail diabetic phenotype, treat them like glass. Glass will break, You're carrying glass with you. You cannot just walk about as you must carry it very carefully. This glass will break. Similarly, these people who are elderly and are frail, you must treat them very carefully. You cannot just treat them as you like with very low BP, very low HbA1c. So what is this frail diabetes phenotype? One is old age, but age is only a number. Okay, and on a lighter vein, when I was studying in college and in school, especially in college, I used to see people retiring at 58. And I was saying, oh, these old guys, they retire at 58 and all that, very, very old. When I'm 64 now, I think, oh, those guys were very young when they retired. I'm 64 and I feel as if I'm 28 or something. So why should these people now feel retire at 58? Why don't they go on up to 75 or 80? They're quite. So age is a number. It is not that everybody at 58 is old or 60 is old or 65 is old. Some people start their careers only after 60, 65. People start running marathon after 65, 70, and then at 90 years they're winning marathon. Today it's not a age is no longer a number. But if you have very long duration, if you have thin and underweight, okay, if you have underlying heart disease, if you have stroke, and especially if you have renal failure, okay, these are all makes you very frail. You cannot over treat these. Already the kidney is affected. Why are you going and now treating HbA1c to 6%, 5%? That will probably kill the patient rather than keeping it slightly higher. So in these people, you have to be very, very careful. Those who have the frail. So as important as it is to intensify the treatment, it is equally important to de-intensify the treatment when it is not indicated. Now, if you look at the levels of clinical inertia, this again, Kamlesh Kunti has raised this. 50% is in the hands of the physician. We make the mistake. Patient will come, A1C is 9, 10, okay, already kidney showing some risk of damage, and then that time they clearly need insulin, okay. And then we say, please sir, you have to take insulin. And patient says, no. My daughter's marriage just took place 3 months back. I ate a lot of sweets. That's why, doctor, give me another 3 months, give me another 6 months. It's very tempting at that time to say, okay, fine. Oh, daughter's married. Okay, then that's fine. You come back after 6 months. He'll come back after 2-3 years because he doesn't want to be put on insulin. Okay, he'll avoid you like the plague. And so he'll come back after 2-3 years. By the time kidney is totally gone. If you had only started the insulin then, you could have saved. But to start insulin, it takes time. In a clinic, you have to teach them how to take the insulin, what will happen if you have low sugar, how to inject, how to do this, you have to convince them first. That will take 15-20 minutes. So we say, all right, next time we'll see. You're in a hurry to go. So we'll say, all right, next time we'll see. Clinical inertia, physician is responsible. 30% is patient. 20% is structural system. The clinic is not designed for that. You need an educator. Somebody will teach them insulin, will teach them something else. Class should be there. The place I'm sitting now is a classroom where every day we take class for patients. You have to teach them. Some people don't have the teamwork. So all these are there. Then they also say there are 200 potential barriers. Not one cause. There are so many causes of barriers. Nobody living with them. He's living alone. He can't afford it. Cannot afford insulin. Cannot do this. Long distance away. I live in a rural area. I live here. Live there. There are hundreds of reasons. 200 reasons. And these are the 200 reasons. There are 76 articles which have reviewed 293 potential barriers. So it's not easy. It's not like, oh, everybody 7, everybody take insulin, everybody. I wish life was so simple. It's not. It's very complicated. Each patient, there are some easy cases you can do, but others you have to spend a lot of time. So they're asking, why don't physicians follow guidelines? Why is there inertia? There are a lot of reasons for inertia, but we must try to overcome as many as possible. Okay. Now this is just again an example to show you. Normally what happens is we start with diet, then we give one oral drug. If that doesn't work, we'll increase the dose. Then we'll give 2 drugs, then 3 drugs, then insulin, then something. By the time you do all that, the A1C is going higher, 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 higher. Already the complication is starting. What if we started early with a little more aggressive approach? Then the whole curve will be shifted down. See, here we're talking about 8 is that line. It's never come near 7. You see the 7 line? It's not touched that even. And yet we are adjusting medicines and everything and keeping it at 8 all the time. If you're really aggressive and prevent clinical inertia, we will move all that. When something doesn't work, we'll start with 2 drugs because we know it's not going to work. then the whole curve will be shifted down. Now it's come below 7. By the time it goes up, again it's come down, again goes up, again it comes down. This is what I showed you in that cartoon of glycemic burden and how to correct the glycemic burden. This is the way you should be approached rather than the first way. Okay, now I'm going to slightly switch tracks and introduce a new concept to you. After that, we'll wind up. When patients come to us with type 2 diabetes, and this is a continuation of the earlier slide actually, you see where insulin came. First we give 1 dose, then we give 2 drugs, we increase that dose, then we give 3 drugs. Now there are 4, 5, so we give 4th drug, then a 5th drug, then that doesn't work, then insulin. By the time we think of insulin, 6 years, 8 years, sometimes 10 years has passed. It's too late. People who come with uncontrolled diabetes, I said from pre-diabetes to diabetes, just when they come to diabetes, they doesn't produce symptoms. They'll delay another 5 years by the time they come to you. So already we have lost 5 years. That inertia has occurred because we didn't diagnose it at all. That time you start the conventional way. I'll first try diet, then I'll try one drug, I'll try another drug. By the time you try all that, his kidney is gone or eye is gone. Okay, you have to work fast. In such situation, you work fast. At that stage, I feel giving a little insulin for about 3 to 4 weeks at the time of diagnosis in people who have completely missed the bus for some time can have dramatic effects. And I'm asking the question, can beta cell be preserved by early insulin treatment? So what I'm trying to say is, if you don't act fast enough, if you don't correct the clinical inertia, beta cell function is going to go down, 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 down. As you age, as you have more duration diabetes, your beta cell function is going to go down. But if you treat little aggressively, maybe you can slow down that beta cell failure. You can slow down by giving early insulin. And I'm going to show you one case where this happened, and we have many papers now which are published on this. This is a 41-year-old male, 7 days duration, just detected 1 week ago. BMI was 25, slightly overweight. Family history was there. Patient was already on sulfonylurea and metformin. But look at the HbA1c, 12.6. Where is 7? Where is 12.6? Patient is having 299, 374. Okay, already on sulfonylurea and metformin. Most doctors, what they'll do, and what I used to do earlier also, you give it a little more time. No, try, come back after 3 months. We'll see whether it will respond and so on. What I decided was sulfonylurea will reduce by 1% maximum. Metformin will reduce by another 1%. So 12.6 will become 10.6. That is nowhere near my target. Whereas insulin, if you give for some time, 1 month, I'm only talking about 1 month insulin, 4 weeks, insulin will definitely bring the sugars down. So what I did in this particular case was, one of my early cases, I gave insulin for 4 weeks, then I stopped it, and then the tablets alone continued. And you can see in the ambulatory glucose profile how the sugars are very high. That yellow means it is very high. And when you see the shaded portion as a normal sugars, and you can see by the end of the first week after the insulin, all the sugars are completely normal now. All the yellow has gone. Okay. Now, he came back again, and you can see the sugars are now absolutely under control like a non-diabetic person. This magic happened because we gave insulin for 4 weeks. If you had continued in the usual way, that yellow would have been there, little less yellow, but then still more yellow will be there. It will go on like that till the beta cell function further goes down. So this was the response. What happened was, you can see the A1C from 12.6 dropped to 4.9. It's an unbelievable value. I've never seen these kind of A1Cs in my life. We were talking about 7 here. It came to 4.9. Since we gave only for 4 weeks, patient didn't have hypo. We took off the insulin, and the A1C was still 5, 6, 5, 6, 6. You can see after 2 years, 2.5 years, still the A1C is below 7%. So there's no glycemic burden here, completely prevented by this massive drop which occurred. You may ask, will it not produce hypo? It will not, because sugars are set so high, and you're giving it only by 4 weeks. If you continued insulin after some time, you will get hypo. But by the time you're stopping the insulin, so this works really well. What really happened was, in this case, the C-peptide levels, the measure of insulin. Okay, the fasting C-peptide is 0.9, and the stimulated C-peptide is 1.6. Now, this is about 50% of the beta cell function. It should be 3 stimulated and about 2 of the fasting. Now, you can see after this 4 weeks of insulin that we gave, C-peptide increased to 4.2, almost like a normal person's beta cell function. So that little insulin that we gave for 4 weeks has reversed the problem that he had in his pancreas. The pancreas is now working very well, and his C-peptide has improved. His insulin reserve has improved. So instead of going down, it's actually improved now. Okay. Now, so this is called as functional recovery of the beta cell. The beta cells were not dead. They were only stunned. Now you've taken away the stunning by giving insulin. And now the beta cells are not stunned, they're working normally. Okay. Then we did a paper. This is Jatinder Kumar Mokhta from Simla. So he was a great follower of mine. And he put about 200 cases, 122 cases, where he gave this intensified insulin therapy. He said, let's do it like a study, sir, and see in my cases what happens. And this was published in 2018. And you can see the reduction in the sugars, the fasting sugar coming down. Postprandial sugar fasting is in blue, postprandial is in red, and you can see that 36 months later, 3 years later, the sugars are absolutely normal. After see where it started, 400, 260, it's completely normal. Okay. He also showed that the A1C came down from 11 to 7, 6, 6, 6, 6. Once it came to 7, again brought down. Now it's 7. Okay, it's maintained very well. Another paper that we published, which is now under press, the larger series, 426 patients, you can see the C-peptide improvement. Fasting, 0.8 became 1.2, 1.02, 1.44 at the end of 1 year. At the end of 2 years, it is still 1. So it's not just temporary improvement that we're seeing. At the end of 1 year and 2 years, the beta cell has actually improved. And the stimulated C-peptide also has gone from 1.6 to 2.5, 2.7. Now it's still settled around 2.09. Okay. Now, another paper from Dallas has shown that such a preservation of beta cell function can occur for 3.5 years. We have shown it up to 2 years, but the study which has shown up to 3.5 years. And how long they gave the insulin? In this particular case, they gave for 2 to 3 months. 2 to 3 months will be given, after that no insulin. And yet they, after 3.5 years, still it is working. Okay. So beta cell function will preserve for 3.5 years after 3 months of insulin treatment. Okay. An intensive, a systematic review and meta-analysis has been done, which shows that this short-term intensive insulin therapy can improve the underlying pathophysiology and thus provide a treatment strategy for modifying the natural history. I showed the natural history going from this way, that way. Now we are reversing the natural history just by aggressive treatment and preventing clinical inertia. And with that, we were able to show, this is the first paper in the world, which we published in July 2013, to show that patients with type 2 diabetes can now live for 40 years or even 50 years after getting diabetes. So they got it when they're 30, 40, now they are 90. We recently celebrated our patients who finished 90 years in this very hall, where we brought them all and then showed. And the conclusion from there was that just by controlling the sugar and pressure and the cholesterol levels, you can make people live even up to 100 years of age. Okay. So to conclude, this is my last slide. What I'm presenting, ladies and gentlemen, is that clinical inertia has to be prevented at every stage of the natural history of diabetes. I'm not aware of anyone who has built such a big thing. They only talk about after you get diabetes, bring it to 7%. If you don't, you're doing clinical inertia. I'm extending that. Yes, that's very true. But I feel there's much more which can be done much earlier. Okay. It's possible to prevent diabetes in those with pre-diabetes. Please tell your friends that if you are in a pre-diabetic stage, you can actually prevent diabetes. It's been proven by 10 trials, not by 1 or 2. Abroad trials, Indian trials, at least 2, 3 Indian trials, at least 4 other trials, Finnish trial, Chinese trial, US trial, UK trial, all have shown that it's possible to prevent diabetes. So why can't we prevent it now? Once diagnosed with diabetes, good control of diabetes can prevent the complications. Routine screening of eyes, kidneys, heart, and feet can lead to identification of complications in the early stage. That's the other thing. They come for diabetic checkup, then we tell, sometimes patients fault, sometimes doctors fault, sometimes systems fault. We don't check their eyes. We don't check their feet. Until some gangrene sets in, we never look at the feet. We don't even take off the socks and shoes when the patient comes in. You're supposed to examine the feet of patients every year, at least once. Look at the eyes of patients every year. You've got low-cost cameras now. You can something like this. Just sit there, take a picture, like a biometrics being done, and you get the retinal picture in a few seconds. And you know whether the eye is affected or not. They're not very expensive, so you can do that. And finally, long-term survival of patients for 40, 50, 60 or more years is possible, and people can live up to their full lifespan. I've been making a bold statement the last few months, and it's been there in the press, saying that patients with diabetes can outlive people without diabetes. Okay, why should a person with diabetes live less than a person without diabetes? In fact, I'm saying they should live longer. So some people may say it's just empty rhetoric. No, I firmly believe in it, because you're detecting your diabetes and treating it. You're also looking after blood pressure. You're following your diet. You're doing exercise. You're going for a checkup often. So if there are any early disease, you'll pick it up. So I'm looking for a day when we can tell all patients with diabetes that you can live up to 100 years of age, if not more. I'm thinking that the future people will probably live 120, 130, even up to 150 years is predicted that human beings are going to live. Already a lifespan is increasing. In many countries, it's already coming up to 90 average. And in India also, it's very rapidly, every 5 years, 5 years, 5 years getting added to India's lifespan. Very soon, I think we'll have a lot of people who are 100 years old and with diabetes who are doing very well. But to do that, you need to do one thing, and that is to prevent clinical inertia at every level. If you do that, then diabetes is no longer a disease, it's just a simple disorder. Thank you. I'm going to stop here and then take questions.
Thank you, Dr. Mohan, Chairman, Diabetes Specialty Center, Gopalpuram, Chennai, for sharing valuable insights on the topic preventing clinical inertia in diabetes. Now we'll move on to the question answer round. Okay, sir. So the first question is, should a diabetic patient consult an endocrinologist or a MD physician? The reason being, India has an acute shortage of endocrinologists.
I don't think it's who you consult which matters. The whole thing depends on what you do, what that person whom you consult does for you. So you can have a very good MD. Why do you need MD? A good MBBS doctor is enough. If that doctor is well trained, if that doctor does all that needs to be done, then it's not your MD or your DM or your DipMD or your MBBS which is going to count. It is what you do with the patient. So I don't have a DM in endocrinology, and I hope I am a good diabetologist. I don't know. World must tell me that. But I don't have a DM. And but all my life I have practiced diabetes, and it's my interest and passion for the disease which has kept me going. I think that's most important. You must have interest, passion, knowledge, and apply that knowledge. Degrees don't count. It always helps that if you're trained in diabetes endocrinology, because then you will know a little bit more, and therefore you can apply all that. Because if you're not trained, you will not know what to do. You will not know about clinical inertia. You will not know about pre-diabetes. You will not know how to prevent eye complications. But so if you do that, it's fine. Whoever treats the patient with diabetes, spend time with diabetic patients. Education is very, very important. You cannot treat diabetes like you treat a fever or a malaria. Just give a tablet to someone and then send them. This is a lifelong disease which needs a lot of commitment, time, passion, interest. If you have all that, it doesn't matter. The degrees are immaterial.
Moving on to the next question. How much can an antibiotic resistant be blamed in today's diabetic burden in India? Diabetes burden in India.
I don't see how an antibiotic resistance can be linked to diabetes unless you're taking a far-fetched route of some infection being there, infection triggering diabetes, and that infection has become antibiotic resistant, and that is leading to diabetes. I think it's a long cock and bull story which you're building around here. I don't think that kind of situation I have seen so far. I would think of much simpler things. Diabetes is due to overweight. Diabetes is due to wrong eating. Diabetes is due to lack of physical activity. Diabetes is due to genes and hereditary factors. Diabetes is due to stress. Diabetes is due to so many things. Diabetes is due to drugs. Steroids can produce diabetes, and many other things. And therefore, if you control, those are all the low-hanging fruit. I think if you focus on those, we'll have much more better opportunity. Yes, of course, infections are not good, and obviously antibiotic resistance is not good. That's not just for diabetes. If you get an infection, then you'll die. If you have antibiotic resistance, then no antibiotic is going to work, and that whether you have diabetes or don't have diabetes, you'll die of septicemia. So that is a separate story altogether. I don't think it's directly linked to diabetes or to this topic.
Okay, so next question. As far as insulin is concerned, what are the reasons why patients try to postpone or avoid it? Do doctors also try to delay insulin infusion?
Yes, I think the answer to both is correct, because from the patient's point of view, one of the reasons is doctors themselves. See, it is like a child, when a child doesn't, behave or something, what do we tell? Oh, boogeyman will come, monster will come. We put the fear into a child and say, if you don't do this, I'll call, that uncle next door will come and hit you, or something like that, or I'll take you to the doctor and he'll give you an injection, and something like that. We keep frightening the children. In the case of diabetes, we doctors also keep saying, next time your sugar is high, I'll give you insulin. Now, what does that mean? Insulin is a bad guy, insulin is a villain, and I'm going to put that villain on you if you don't control your diabetes properly. This is wrong. I think one of the reasons why I give insulin early itself, when they're diagnosed itself, to tell them, look, insulin can be stopped, okay, and I'm giving you this insulin, which is a lifesaver. It's going to change your natural history. And all those, believe me, all those whom I've given that insulin early in that first 1 month, thereafter for years and years and years, they don't need it. But with that, one more thing has happened. They've got over the fear of insulin. So next time I tell them, oh, that one you gave 5 years ago. Yeah, okay, I'll take it for a few more months, doctor. Yeah, a few more. Now I'm ready. Other than that, what's happening is you're just frightening people and saying insulin, 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 as if some kind of an enemy. It's a lifesaver. So it's our approach to the patient which is completely wrong. And that's the reason why. That's the first point. Second point is, of course, nobody wants to keep injecting themselves. So given a choice, even I'll say, no, give me a tablet, doctor, I'll be happy. Unless you explain to them why you're doing it. That's the second point. Third is insulin is expensive. Compared to tablets, most insulins are expensive. Fourth, they're also worried about their lifestyle. You take insulin, you can't eat now, lunchtime, all of you are listening there, wondering why this guy will, when will this guy stop so they can go and have lunch, you must be thinking, especially if some of you are diabetic and already had your insulin in the morning, you'll be wondering when this fellow stops, then only I can go and have my lunch. So that's the thing, we don't eat in time, you're going to get low sugar. You're going to get a low sugar reaction. With tablets, it's a little less common to get that. So all these are the reasons. But the first thing to tell every patient with diabetes is, ultimately you've got one savior there. It's like having God, nothing else is there. Finally, we'll go to God and God will save us. Like that, insulin must be given the position like God for diabetes. I think that's your ultimate savior as far as medicines are concerned. God is the ultimate savior. But here you've got the ultimate savior as far as treatment is concerned. Nothing else there. We've got insulin. Don't worry. We'll always use it. And like a trump card, so when you play cards, you don't throw the trump card first, You keep it for the last. Then here's my trump card. Now I take it, and then now I hit it. So like that, I think insulin must always be used. And if it has to be used early, I am not saying that in every patient with type 2 diabetes you should treat it. I am only saying with severe uncontrolled diabetes, when they have missed the bus for a long time, 6 months, 1 year, 2 years, they've already missed. That's the patient whom I'm saying. And one way to know that is the HbA1c level. HbA1c level should be below 6.5 to say you're not diabetic. If it is 7, I'm not going to start insulin for it. Or if it's 7.5, or if it's 8, I'm not going to give insulin. Just one tablet, metformin is enough, or something else is enough. But suppose he presents with 11, 12, 13 A1C. He has missed for 4, 5 years. And before you realize it, next year itself, you may have eye trouble or kidney complication due to diabetes. That's the time when you have to really hurry and do it. So suppose a cyclone is going to hit somewhere. You can't be, the laissez-faire at it. Oh, let the cyclone come. After it hits, we will see. Immediately we evacuate people. We get ready for it, isn't it? We take preventive action. So like that, we must be prepared for these things and treat at the right time using the right tools. If you do that, then only you will be able to control diabetes. So insulin is not needed for everyone. Physicians are also to be blamed, because the way they talk about insulin is as if it's a very wrong thing. Second thing is, if the patient says something, no, I don't want it now, we give up too easily, because we think, oh, then I can see my next patient. By the time, get rid of this guy, I can see the next patient. That's very wrong. As far as that patient is concerned, it may be his life and death situation. So if you're really convinced about it, go that extra mile. Tell the patient, convince the patient about the need. Then very often physicians tell me, why, Dr. Mohan, I don't tell. The moment I tell insulin and write the insulin, he'll go next door to my competitor who will then tell him, no, 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 insulin not needed, just to keep the patient. Let them go. No, let them go. If you're convinced that what you said is right, and if that patient has no faith in you, and he is going to your competitor, let him go. He'll come back to you later. Because if you are right about that, then at some point, even your competitor, whatever he did, will not control the patient, will come back to you later. So for all those silly reasons, don't stop yourself from doing what is the right thing. The right thing needs to be done, it has to be done. Whether the world appreciates you for doing it or your competitor criticizes you for doing it, doesn't matter. If you think it's the right thing, you have to do it. Otherwise, there's no way we can prevent clinical inertia.
Okay, sir. Moving on to the final question. Please update about the stem cell therapy in diabetes. Can we cure it by 2025?
Put a date also. Why not 2020? I'll be a little more optimistic. So, stem cell therapy, I can talk a little bit about it because we do it in our own labs. We have been working on stem cells for the last few years. We produced a model of insulin secreting cells from stem cells. We're able to bring down glucose levels. So one of my scientists actually almost made a breakthrough, but then there are technical hitches, and then scaling it up is a big problem. So there are many groups in the world working on it. 2025 is a very ambitious target, but it's still 6-7 years away. Maybe it will happen. If it happens, it's really good. If really stem cells were able, it's not impossible. You can make it. Okay. Less likely is pancreas transplant or islet cell transplant because you need a human pancreas for that, which is very difficult unless you make a 3D construction of it which succeeds or something. But stem cells are easier. You got the stem cells, you convert it into a beta cell. That beta cell must respond in the body just like our human body responds. Then there is no risk. But if that beta cell thing that you produce, if it starts growing and becomes a tumor or a teratoma and starts producing too much of insulin, it will kill you, so due to low sugar. So that's why we have to be very careful in human beings. It's not that we cannot produce stem cells, it's not that we cannot produce insulin. It must be controlled in such a manner, just like God designed our pancreas. And it's very difficult to imitate God. God is much more superior to us. So when He creates a pancreas, no human being produces a pancreas, you must now equate it with what He produced and bring it to the same level. It must respond in the same manner. It must stop responding when it is thing. Nature is so great, and so to imitate that and to produce an organ like that which will respond so well is difficult. And on the other hand, and then to keep those cells going, you probably need immunosuppressive drugs, you need all kinds of other treatment. Instead of all that, just take your insulin and be happy. We are showing that people are living 60, 70 years. What more you want? They don't have complications. Few pokes, that's all. That also you got pumps now and things which are much easier to give. Artificial pancreas is coming, which will decide how much insulin to give itself. If the costs come down, what Indian biomedical engineers, if any of you are listening there, what I would like you to do, our pumps now cost 2 lakhs, 3 lakhs. Why don't you bring a pump for 5,000 rupees? Should be able to do it. Make a pump of 5,000 rupees, and to every patient will give it. That's it. Then no need for stem cells or any cell. This pump will take care of everything for you. Okay, without any risk, without anything. That is where I think our technology should be going. We should be using artificial intelligence, using all this to bring in all this, so that I'm sure in the next 5 to 10 years we are going to do all this.
Thank you so much, sir. Unfortunately, we won't be able to take all the questions due to time constraints. If you have any other questions, please send them at editor@ethealthworld.com. It was an engaging and insightful talk, and I hope that all the participants have enjoyed this session. The recording of this webinar will be made available on ethealthworld.com. Thank you everyone for joining us. Goodbye.
Thank you so much.